My name is Dr. Naveed Frutan, a member of the Kaiser Permanente Inland Empire Internal Medicine Residency Group, here alongside my colleagues Dr. Amina Medwala, as well as Dr. Huyen Nguyen, with our faculty member Dr. Timothy Devine, here to present a rare left-to-right shunt, a case of coronary pulmonary artery fistula. Coronary pulmonary artery fistulas are a rare pathologic left-to-right shunt. They are hypothesized to emerge from the failure of involution of additional anterior truncus branches that connect both the left and right main arteries. Largely an incidental diagnosis, it may manifest as typical cardiac symptoms, including but not limited to angina, dyspnea, congestive heart failure, myocardial infarction, endocarditis, and/or even sudden cardiac death. This case study aims to overall characterize the clinical and diagnostic indicators while highlighting the management of this rare phenomenon. Our case involves a 41-year-old male with a history of hypertension whom presented with left-sided weakness and facial droop. CT had demonstrated subacute to chronic infarcts involving the basal ganglia. A transthoracic echocardiogram was ordered in the setting of a standard stroke workup and revealed a suspected diastolic shunt involving the pulmonary artery. This prompted further assessment and evaluation, leading to a cardiac CT, ultimately demonstrating a tortuous coronary to pulmonary artery fistula coming off of the proximal LAD, superiorly and laterally surrounding the main pulmonary artery. It was ultimately determined that this fistula was congenital and likely benign in nature. The cardiac CT imaging is highlighted in the center of our screen. As you can see in the top image, the blue arrows are highlighting the two coronary pulmonary artery fistulas coming off of the proximal LAD. Physiologically, coronary pulmonary artery fistulas are left-to-right shunts, resulting in a coronary steal phenomenon that can ultimately lead to myocardial ischemia via hyperperfusion throughout coronary distribution distal to the fistula. Both MRAs and CTAs improve the overall detection rate and provide insight into the complex anatomical structures of these fistulas. There are no optimal treatment strategies available to date due to the low prevalence of this pathologic process, as well as limited studies and documentation. Spontaneous closures of these fistulas have infrequently occurred in approximately 1 to 2% of documented cases. However, most still required intervention. Small fistulas that were incidentally discovered can be managed conservatively with optimal medical therapy. However, those that are symptomatic can be closed with either surgical or percutaneous intervention. Both of these interventional profiles have an acceptable safety. However, percutaneous intervention appears superior as there were no significant post-operative complications, nor mortality nor morbidity. We hope that this case study will highlight and bring to the forefront a rare phenomenon to characterize both the clinical and diagnostic indicators, while also highlighting the management of this pathologic process. We thank you for your time.